Okay, let's talk about something many of us might notice, maybe when brushing our teeth. Ever seen your gums kind of pulling back, leaving a bit more tooth showing, maybe feeling that wince when something cold hits it?
Mm-hmm. That sensitivity?
Yeah, exactly. And it seems like a small thing, maybe just looks a bit off, but it's actually more than that, isn't it? It can lead to real sensitivity, even decay on the root.
Absolutely. It impacts your daily comfort for sure, and it can signal deeper issues.
So today we're doing a deep dive into, well, a really refined and pretty groundbreaking concept for treating this gum recession. It's not just, one specific technique, but more like a whole philosophy, a comprehensive approach that's really changing periodontal plastic surgery.
That's a good way to put it, a philosophy.
Yeah. So the idea here is to kind of distill the essentials, get you up to speed quickly on this advanced method, and really understand why it's such a leap forward.
Indeed. And what's really fascinating, I think, is how this concept shifts away from some of the older, maybe more limited ways of thinking. It gives us this complete, logical, evidence-based framework for actually treating the problem.
A framework, okay.
Yeah, so it's not just about patching the symptom, covering the root. It's about understanding the root cause, pun intended, maybe.
Ah, nice.
But seriously, understanding the foundation,
Yeah.
right down to the microscopic level, and how that guides our clinical decisions for, lasting success. That's the real game changer here.
Okay, so let's start right at the beginning then. Gum recession. What exactly is going on when we say the gums are receding? Is it just shrinking?
Well, fundamentally, yeah, the gum line is moving down obliquely away from the crown of the tooth.
Right.
So more of the tooth's root surface gets exposed. Think of it like a collar around the tooth neck, just getting shorter, pulling away.
Okay.
But it's not just the pink stuff you see. It involves the gingiva, yeah, but also the cementum on the root, the underlying bone, even the periodontal ligament that holds the tooth in.
Wow, so it's the whole support system.
Exactly. It affects that whole unit.
And what are the real world consequences for someone? I mean, aside from maybe not liking how it looks, are there bigger problems?
Oh, definitely. Aesthetics are a huge driver for treatment, no doubt, especially on the front teeth. People notice it. But the clinical impacts are significant. The big ones are dentinal hypersensitivity, that sharp zing you get from cold, hot, sometimes even air.
Ugh, that's the worst.
Right. And also root caries, cavities basically, but forming on those exposed root surfaces. See, the root isn't covered by hard enamel like the crown is. It's much softer, much more vulnerable to decay once it's exposed.
Ah, okay. So it's a real weak spot.
It really is. And gum recession is incredibly common. Lots of people deal with it.
You mentioned that collar analogy earlier. Can we zoom in a bit on the different parts of the gum? It's not just one uniform layer, is it?
Not at all. It's quite intricate. You basically have two main parts right near the tooth. There's the free gingiva,
Yeah.
which is that sort of loose edge right around the tooth, like a tiny turtleneck collar. It's not stuck down.
Okay, the very edge.
Exactly.
Right.
Then below that, you have the attached gingiva. And as the name suggests, this part is firmly attached, anchored down to the underlying bone. It gives everything stability.
Right.
And then, fill in the space between the teeth, you've got the papilla, that little triangle of gum tissue. All these parts need to work together for a healthy seal.
And I've definitely heard people talk about gingival biotypes. Like, some folks just have thicker gums naturally. How important is that for recession?
Oh, it's pivotal.
Yeah.
Absolutely crucial. Gingival biotype refers to the inherent quality, the thickness of your gum tissue and the underlying bone. We generally talk about thick versus thin biotypes.
Okay.
A thick biotype usually means robust gum, thick underlying bone. It's generally tougher, more resistant to recession, more resilient to trauma.
Makes sense.
A thin biotype, on the other hand, means more delicate, fragile tissue, often with thinner bone underneath. It's just inherently more susceptible to receding, especially from things like brushing too hard.
So your natural gum blueprint really matters.
Profoundly. It doesn't just influence your risk of getting recession. It critically affects how predictable treatment will be. Understanding your specific biotype is often step one in figuring out the best treatment path.
That makes a ton of sense. Wow, okay. So just understanding the landscape is pretty involved. But let's shift to the why. Why does recession happen? Is it really just brushing too hard, like everyone says?
Ah, the million-dollar question. And no, it's rarely that simple. That's a key takeaway. If you connect this back to the big picture, understanding these underlying factors is so important for long-term success, not just patching things up.
Right.
Gun recession is almost always multifactorial. Think of it like this. You have contributing factors that kind of set the stage, make you more vulnerable.
Predisposing factors.
Exactly. And then you have triggering factors that actually push it over the edge and cause a recession to happen.
Okay, so what are some of those contributing factors, the ones that make you vulnerable?
Well, number one is often tooth malposition.
Mm.
If your teeth are crooked, tilted, crowded, rotated,
Right.
it can mean the bone over the root surface is naturally thinner in some spots, or the gum tissue gets stretched thin. Then, as we just discussed, your periodontal biotype. A thin biotype is a major contributing factor.
Inherited vulnerability, basically.
Pretty much. And also, sometimes, strong frenal attachments. You know those little muscle fibers you can feel connecting your lip or cheek to your gums?
Uh-huh.
If one of those attaches too close to the gum margin, it can literally pull on the gum every time you move your lip or cheek, potentially contributing to a recession over time.
Wow, I never thought about that. Okay, so those set the stage. What about the triggers, the things that actually cause the recession?
Right. The triggers are often what people notice or associate with it. Mechanical trauma is a huge one. Aggressive toothbrushing, using a hard bristled brush, scrubbing back and forth, that's a classic.
Yeah, the scrubbing.
But it can also be things like oral piercings, constantly rubbing against the gum, or even improper, aggressive flossing techniques.
Okay.
Then there's chemical trauma, maybe from certain substances. Smokeless tobacco is a big one there. Inflammation is another major trigger, specifically inflammation from bacterial origin.
So gum disease, periodontitis.
Exactly. The body's inflammatory response to plaque bacteria can destroy both gum tissue and the underlying bone, leading directly to recession. And lastly, sometimes poorly done dental work, like fillings or crowns with rough edges or ledges near the gum line, can irritate the gums constantly and cause them to recede.
It really is a combination of things then, or rarely just one culprit.
Precisely. It's an interplay.
Okay, so we've covered the gums, the factors, but sometimes the tooth itself has issues that need dealing with before you even touch the gums, right? Like wear or damage.
That's a critical point, and the next logical step in planning treatment. Very often, when you see gum recession, you also see some loss of the tooth structure itself on that exposed root surface. This could be from abrasion, like from brushing or chemical erosion, maybe acid reflux or diet, or even trauma. We actually classify these tooth defects based on their location and depth.
Class A, Class B, plus minus. I've seen those classifications.
Exactly. And addressing these is vital before or sometimes during the gum surgery. You wouldn't put a new frame on a damaged painting, right? You need to restore the canvas first.
Good analogy. So how do you decide? Do you fill a defect or does the gum surgery handle it? What's the pre-surgical thought process?
It's all about pre-surgical management. We look at the type and depth of that tooth defect. Is it shallow, just a little notch? Maybe a simple composite filling, restoration is enough to smooth it out and create a good surface for the gum graft. But if the defect is deeper, or if it significantly changes the shape of the tooth crown near the gum line, then we often need more involved reconstruction. This is where coronal reconstruction comes in.
Coronal reconstruction. So rebuilding the visible part of the tooth.
Precisely. Rebuilding the crown portion, often before the gum surgery, to ensure everything looks harmonious in the arch. A key part of this is figuring out the ideal location of the CEJ, the cemento-enamel junction.
The line where the enamel meets the root.
Exactly. We need to know where that should be, ideally, so we can reconstruct the tooth shape correctly. It's about creating that perfect, healthy surface for the new gum tissue to heal against.
Okay, that preparation makes sense. Which brings us, finally, to the main event, this tunneling concept. It sounds really innovative. What's the basic idea?
It really is a minimally invasive breakthrough. The core idea is quite elegant, actually. Instead of making vertical cuts on the outside of the gums, which can leave scars and affect blood supply.
Right, the older methods often did that.
They did. With tunneling, the surgeon makes tiny incisions inside the gum pocket, that little space around the tooth. Then, very carefully, they create a pouch, or rather a continuous tunnel, underneath the existing gum tissue, connecting these pockets horizontally across the teeth needing treatment.
Like going under a carpet without cutting it.
That's a perfect analogy. You're creating space underneath without making those visible surface incisions. This tunnel then allows the surgeon to slide a connective tissue graft, or sometimes just reposition the existing tissue into place.
Okay, wow. So what are the big wins with this approach? Why go under the carpet?
The advantages are pretty significant. Less trauma, number one. No vertical releasing incisions means less cutting, less disruption of blood supply.
So faster healing, less pain.
Generally, yes. Faster healing, less postoperative discomfort. And critically, it protects the papillae, those little triangles of gum between the teeth. They are so important for aesthetics, preventing those black triangles. Tunneling helps preserve them much better.
Aesthetics are definitely a big plus then.
Huge. The cosmetic outcome is often superior, and importantly, it tends to be more predictable in achieving full root coverage, which is often the main goal.
Can you give us a quick walkthrough of the steps? How is the tunnel actually made? Simplified, of course.
Sure. So first, the exposed roots are meticulously cleaned and prepared. Root planing. Then, those small incisions are made within the gum sulcus, the pocket around each tooth involved.
Inside the pocket.
Inside the pocket. Then, using specialized, very fine instruments, the surgeon carefully dissects and lifts the tissue, creating those individual pockets and then connecting them laterally under the papillae to form one continuous tunnel space.
Delicate work.
Very delicate. The papillae themselves are gently elevated or prepared to allow the tissue to move coronally, upwards. And the final step before placing anything is to verify that the whole tunnel is continuous, that there are no perforations or tears.
Meticulous.
Okay, tunnel created. Now, what goes in it? You mentioned grafts or repositioning. It sounds like there isn't just one answer. It's tailored. It's exactly right. This is where the concept becomes really versatile. It's not one size fits all. It's about choosing the right approach for this specific clinical situation, all within that minimally invasive tunnel framework.
Makes sense.
So sometimes the main goal is actually to create new keratinized tissue, that tougher, pinker gum tissue, if you don't have enough of that attached gingiva we talked about.
Right, the stable part.
Exactly. In those cases, we might use what's called an exposed graft. A piece of connective tissue is placed, but a small portion is intentionally left slightly exposed in the tunnel. This seems to stimulate the body to create that tougher tissue type.
Interesting. So that's for building new tough gum. What if you just need to cover the root and thicken the existing gum?
That's probably the more common scenario. For that, we typically use a submerged conventional graft. A piece of connective tissue, usually taken from the palate, is placed in the tunnel and completely covered by the overlying gum flap. Its main jobs are root coverage and adding bulk, thickening the biotype.
Okay, submerged means fully covered.
Correct. Then there's a variation called the submerged micrograft. Similar idea, fully covered, but instead of one solid piece of tissue, we use tiny, fragmented pieces of connective tissue.
Why fragmented?
Well, it might be useful when treating multiple adjacent recessions. You can distribute these small pieces more easily, and some believe it might reduce the amount of tissue needed from the donor site, possibly making that part easier for the patient.
Okay. And what if you actually have enough good gum tissue, it's just slipped down?
Great question. That's where displacement comes in. Technically, it's often called a coronally displaced flap, done via the tunnel approach. Here, you don't necessarily add any graft tissue. You just create the tunnel to free up the existing gum tissue and gently move it upwards, coronally, to cover the recession, and then suture it in its new position.
So you're just repositioning what's already there.
Exactly. This works well when there's already a decent amount of thick, keratinized tissue present. It just needs to be shifted. And often, especially in complex cases, we might use a combined approach.
Mixing and matching.
Precisely. Maybe an exposed graft in one spot where you need new tissue, and just displacement next door where you don't. The beauty of the tunneling concept is this versatility. It allows for really precise, individualized treatment plans.
That really highlights the flexibility. Okay, so you've done all this intricate work inside the tunnel. How do you make sure everything stays put while it heals? Sutures must be pretty important here.
Absolutely critical. The sutures in tunneling aren't just, closing an incision like you might think. They have very specific, crucial jobs.
More than just holding edges together.
Much more. They are used to securely anchor the graft, if one was used, in the desired position within the tunnel. They maintain the tunneled flap itself in its new coronally advanced position, and they precisely control that upward movement of the gum tissue.
So they're actively positioning things.
Actively positioning and stabilizing. Without really precise suturing, the whole construct could potentially slump back down.
Yeah.
And you wouldn't get the root coverage you aim for.
Makes sense.
And interestingly, the contact points between the teeth, where they touch, often play a key role in providing anchorage for these sutures. Sometimes, if the contacts aren't ideal, we might even need to temporarily build them up slightly with bonding material just to give the sutures a stable anchor point.
Wow, that level of detail is amazing. It's really microengineering almost.
It kind of is, yeah. Very precise.
Okay, so we've gone through the problem, causes, prep, the tunnel solution itself. Let's bring it home. Who is this really for? What kinds of recession can be treated this way? And what are the results people actually see?
Right. So this comprehensive tunneling concept is generally indicated For most of the common types of recession we see clinically, what we classify as Miller class of 5, 2, or sometimes 3 recessions. It can be used for single teeth, multiple adjacent teeth, or even continuous recession across several teeth.
So pretty broad applicability.
Very broad. And deciding which specific technique within the tunnel concept to use exposed graft, submerged, displacement micrograft, or a combination comes down to assessing those key clinical factors we touched on earlier.
Remind us what those were.
Sure. Number 1, the height of existing keratinized tissue. Do we need to make more, or is there enough? Number 2, the depth of the vestibule, that space between cheek and gum. Number 3, the gingival biotype, thick or thin. And number 4, the presence and depth of any root surface defects.
So those 4 factors guide the specific choice.
Exactly. They form a kind of decision tree that points towards the most appropriate and predictable technique for that individual patient situation.
And the outcomes. What are the tangible results, the clinical effects?
The results can be really significant and transformative for patients. The primary goal for many is achieving root coverage, getting that exposed, sensitive root covered back up. And this approach has a high predictability for achieving that.
That's huge for sensitivity and aesthetics.
Absolutely. But it does more. Depending on the technique used, it can also create new keratinized tissue where needed, increasing that protective band of tough gum. It achieves gingival thickening, making thin tissues more robust and resistant to future recession. It can modify the position of the mucogingival junction, that border between the firm gum and the looser cheek lining. And it can sometimes help reduce the depth of the vestibule. All of these contribute to a healthier, more stable, more aesthetic long-term result.
It really sounds like a comprehensive improvement, not just a cosmetic fix.
That's the core philosophy, addressing the underlying issues for a predictable, stable, and aesthetic outcome.
Wow. This whole deep dive really drives home how a deep understanding of the biology, the anatomy, combined with this really sophisticated, minimally invasive surgical approach can lead to just incredible results, a healthier smile for sure.
Yeah, it's built on that detailed understanding and precision, moving way beyond just simple fixes.
It really underscores how medicine and dentistry are constantly evolving, doesn't it? Finding ways to be more effective, yes, but also gentler, less invasive, improving the patient experience too.
Absolutely. That drive towards minimally invasive, highly targeted treatments is happening across many fields.
Yeah, and it leaves you thinking, doesn't it? How many other areas in health, in medicine, could really benefit from that kind of paradigm shift towards these comprehensive, minimally invasive, highly personalized approaches? What other tunnels, so to speak, are out there in science, just waiting to be explored for, really profound clinical impact?
That's a great thought to end on. The potential is definitely there.